Today we're going to talk a little bit about complications of pregnancy with beta strep status. We've all heard about strep infections. Usually we talk about strep throat or beta strep. B strep infections in newborn. Onset disease, which occurs in the first week of the life of a newborn, is the one that we're going to talk about today, because early onset causes sepsis, pneumonia, and sometimes even meningitis of newborns. When I first started nursing, I didn't even know that GBS was a problem in the newborns, because once the baby was born, we went home, and I didn't know that there was this problem. And even though, the majority of babies do just fine and don't have group B strep, there was a small majority that would get really sick with sepsis or pneumonia or even meningitis, and some of them would even die. So what they did was that with this group B strep, they did some studies, and they know that about 25% are women that come in for prenatal care or come in to deliver. 25% are women actually have this group strep in the genital area, which is the vaginal and rectal area, and it causes no harm to them and no harm to the baby. But there are a few that when the mom has group B strep in the vaginal or rectal area, that when the baby is born, some of those babies don't get sick and do fine, but some of them, a few of them do. And we know we're all about improving outcomes, and we want everybody to have a good outcome. So what they've done is they've done some prophylactic or preventive measures to reduce the incidence, and also have a better handle on how to manage those babies that do get sick. So that's what we're going to talk about, is group B strep. Just some facts on it. In the United States, it is the leading cause of meningitis and sepsis in a newborn's first week of life. 25% of pregnant women carry group B strep in the rectum or vagina. But this is an interesting thing, is a woman who tests positive and gets antibiotics in labor has only a 1 in 4,000 chance of delivering a baby with the disease. That's pretty good compared to 1 in 200 chance if she doesn't receive antibiotics during labor. So that little information right there lets you know why we treat those women, that 25% that actually test positive for group B strep during their pregnancy, to make it a 1 in 4,000 chance versus a 1 in 200. We know that group B strep poses, the one in the genital tract, the colonization there, poses the most serious threat to the newborn. So that's the one that we're concerned with. We know that there's certain people that will be more prone, babies, their babies will be more prone for meningitis and sepsis. And those babies that are born premature, they have less immunity, less fighting factors against infection. We already talked about rupture of membranes. Greater than 18 hours increases the chances of infection, including group B strep that is in the vaginal rectal area. Any mom with a fever during labor, we're very suspicious that maybe they might be getting group B strep. If a mom has had a previous infant with GBS infection, she's definitely at a risk and probably will be treated prophylactically. We test all our women between 35 and 37 weeks gestation. We swab their vaginal area. We send it out for a culture to see if it's positive or negative. If it is positive during at that time, she's at an increased risk factor for her baby being sick. Demographically, we can say the young age and the African American are a higher risk factors. And again, those with positive colonization between 35 and 37 weeks gestation are a higher. Sometimes we'll see group B strep in the urine as well, earlier before that. But when we actually test our women, they're between 35 and 37 weeks gestation. So the guidelines say to screen women at 35 to 37 weeks with a vaginal and rectal culture, which we do. We send it off for a culture, which takes a couple days. If they've had a previous history, of course, or current, if it comes back positive, we're going to treat them per guideline. If she's scheduled for a C-section and her bag of water hasn't broken, we do not need to do the antibiotic treatment. But if she ruptures before she's sectioned, she does. And then again, in a nice world, we know everybody's culture because they all have the test at 35 to 37 weeks. But we know there are some women who do not go to prenatal care, and they just show up and they deliver. It could be lack of access, insurance reason, but it could be cultural too. Some women do not see pregnancy as an illness, so don't come to the hospital or a doctor until they're ready to deliver. But regardless, there are some women who we don't have a culture result. So if there's no culture, the standards say if they're less than 37 weeks, their bag of water has been broken, then greater than 18 hours, or if they have a temp of 100.4 degrees or greater, they need to be treated with antibiotics. So how do they test? At 35 to 37 weeks, they just do that sterile swab. It's collected from the vaginal rectal area, and then they send it to lab. If it comes back positive, we know that that newborn is at an increased risk for group B strep infection if their mother is positive. So we know that we can prevent it by giving moms, when they're pregnant, antibiotics during labor. Now, only during labor is it going to make any sense because the bacteria grows so quickly, it does not make sense to treat them prior to labor. Usually we give IV penicillin is the drug of preference. Now, I'm going to say that depending on the formulary of the hospital, there may be a derivative of it. We give a loading dose of 6 million units, and then we give a maintenance dose of 3 million units every 4 hours until delivery of penicillin. For a baby to kind of be safe from our prophylactic therapy, we need to give the loading dose and then the first dose 4 hours later. It does not prevent the late onset, but we're worried about that first week of life, that early onset of beta strep. For the future, we know that they're working on a group B strep vaccine. As of today, there isn't one. So really the only thing that we can do to prevent or to decrease the incidence is to give our patients antibiotics prior to delivery to protect the baby from the disease. If a woman is allergic to ampicillin, when they do the culture, they can see what grows and they will use some other antibiotic that she's not allergic to. And that's it for group B strep.